Hello and welcome everyone. Today we will be discussing regarding the interventional therapies for pulmonary embolism. We already know about the thrombolysis and those parts of anticoagulation. What we will be going in details is the latest studies regarding the interventional part of pulmonary embolism, how the study is advancing over there. So coming briefly to pulmonary embolism, it is one of the most common cause of cardiovascular death. It is one of the leading cause of preventable in-hospital death. It is associated with high morbidity and mortality despite advances in the medical science. Clinical presentation is variable, making the management extremely challenging, especially if the patient is already in the ICU. Emboli usually originate from the proximal deep veins in the leg, and the obstruction of the pulmonary artery increases the right ventricular afterload. The right ventricular dysfunction thus leads to decreased cardiac output and systemic hypoxia. Vasoactive substances cause vasoconstriction, and this may progress to acute right-sided heart failure and a circulatory collapse. The risk stratification guides the treatment. The classification is done based on the risk of early death, that is low risk, intermediate risk, and intermediate low risk, intermediate high risk, and high risk. Usually clinical scores like PESI, SPESI and biomarkers like troponin and BNP are done. We will not be going to the details of this part. Imaging also helps here. So now we'll be going into the established medical therapies that most of us already know. Anticoagulation is the mainstay. DOACs are preferred when appropriate. Systemic thrombolysis is indicated in high-risk patients. The limitations is there is an increased risk of major bleeding, and it is not suitable in all cases. So in anticoagulation, the options that we have are the DOACs, the low molecular weight heparin, vitamin K antagonist, that is warfarin. The choice here depends on the renal function, the presence and absence of cancer, and patient preference. The duration of therapy varies based on the risk factors. Systemic thrombolysis is done with agents like alteplase, urokinase, streptokinase. Standard dose is alteplase 100 mg over 2 hours. It reduces mortality and the recurrence of high-risk pulmonary embolism, but it is associated with high bleeding risks, especially intracranial hemorrhage. Reduced dose regimens are under investigation. The limitations of this established therapy is the significant bleeding risk that we have already discussed, and its contraindication in many of the cases, especially when the patient is very sick. And anticoagulation alone in these cases is usually not sufficient, and need for therapies with better safety profile is the need of the hour. So interventional therapies are one of the very important factors which will be impacting the outcome of pulmonary embolism, especially in ICU and sick patients where the thrombolysis has a lot of contraindications. The aim is to rapidly reduce the thrombus and improve the right ventricular function. So the potentially lowering the bleeding risk compared to the systemic thrombolysis makes these interventions more important for us. So the types of interventional therapies that are being done are the catheter-directed thrombolysis, ultrasound assisted catheter-directed thrombolysis, aspiration thrombectomy, and pharmacomechanical catheter-directed thrombolysis. So coming first to what is catheter-directed thrombolysis, it is a direct delivery of the thrombolytics into the pulmonary artery. It uses lower dose of the thrombolytic agents, so decreases the risk of bleeding, and the devices like Unifuse, Pratt-McNamara catheters are used for this purpose, and it may reduce the bleeding complications compared to the systemic therapy. Next is ultrasound assisted. It combines this with the ultrasound energy. Ultrasound disrupts the fibrin, enhancing the drug's penetration. The devices here used are the ECOS endovascular system, and it has shown to improve the right ventricular function and reduce the pulmonary pressures. Aspiration thrombectomy, it is the mechanical removal of the thrombus using the aspiration devices. Large bore catheters allow for the extraction of the thrombus. Devices like flow retriever, indigo aspiration system are used for this, and it is useful for patients who have absolute contraindication to thrombolysis, so you can't give even those small amounts that you are giving in the CTT.
So next is the pharmacomechanical CDT. It combines the mechanical fragmentation with thrombolysis. The device is the Bush's endovascular catheter. It's an expanding basket which creates channels within the thrombus for the drug's delivery, and it may enhance the thrombolytic activity. So we look at these studies that have been done using various of these techniques. The first is the Ultima trial. The patient population is 69 with acute intermediate risk pulmonary embolism. The inclusion is hemodynamically stable patients, right ventricular to left ventricular ratio more than 1 on echo. The exclusion being high risk of pulmonary embolism, high risk of death, that is hemodynamic instability, and contraindications to thrombolysis. The intervention here used is the ultrasound assisted catheter, the ECOS system, and altiplase has been used at 10 to 20 milligrams over 15 hours. The comparison group was standard anticoagulation alone. Anticoagulant use was unfractionated heparin. The results showed that in terms of efficacy, there is significant reduction in the RV to LV ratio, that is 0.3, minimal change in the RV to LV ratio seen in the control group, p value less than 0.01, so it is statistically significant. There is a reduction in the pulmonary artery pressure within 12 hours. In terms of safety parameters, minor bleeding occurs in 3 patients with the ultrasound technique and one in the control group. No major bleedings or intracranial hemorrhages have been reported. One death in the control group is due to pancreatic cancer, which is unrelated to the pulmonary embolism. The next is the Seattle 2 trial. It is 150 patients of acute pulmonary embolism, 31 with massive high risk pulmonary embolism, 119 with intermediate high risk. The inclusion criteria is evidence of RV dysfunction, elevated cardiac biomarkers, exclusion being contraindication to thrombolysis. And the intervention used is again the ultrasound guided technique, the ECOS system. Thrombolytic agents used over here is a little different, that is 24 milligrams of RTPA and administered over 12 to 24 hours, depending on whether it is unilateral or bilateral. And in the comparison group, to note, there is no such comparison. It's a single arm study. Result shows a reduction in the RV to LV ratio and p value less than 0.01, which is statistically significant, and there is a reduction in the pulmonary artery pressure, and major bleeding was seen in 10% of the cases, no IC hemorrhages, and one death which was unrelated to the treatment. But to note, there is no control group, so we can't really check the efficacy. The next is the FLAIR study. It is 106 patients with acute intermediate risk of pulmonary embolism with RV to LV ratio more than 0.9 here. This is based on the CTPA findings. In hemodynamically stable patients, again the exclusion are the same, high risk and contraindications to anticoagulation and thrombectomy. The intervention here used is the mechanical thrombectomy, and flow retriever system has been used. Percutaneous mechanical thrombectomy performed via the femoral vein axis. No use of thrombolytic agents has been done over here. Again, the comparator group is not there, so it's a single arm study. The results, however, show efficacy in terms of reduction in the RV to LV ratio, and which is very significant, and there is a reduction in the pulmonary artery pressure as well. Adverse events noted are 3.8% of the patients had major adverse effects, one major bleeding, and no device related deaths. Majority of the patients did not require ICU stay post the procedure. However, there are limitations that there is no control group, so we can't really check the efficacy and safety. And finally is the Canary study. It is a study which was done with 288 patients, terminated early with just 94 patients due to COVID-19. And the inclusion criteria is that there is acute intermittent high risk patients with RB to LB more than zero point 0.9, elevated cardiac troponin levels. The exclusion here is high risk PE and contraindication to coagulation and thrombolysis. The intervention used is catheter-directed thrombolysis, is the Craig McNamara catheter with altiplase. The dose, however, used is a little different again, 12 for unilateral and 24 for bilateral, administered over 24 hours. And the comparison is standard anticoagulation with enoxaparin. And the results show efficacy of no significant difference because probably of the past study. But the important finding of the study is the 3 months right ventricular function, which was significantly better, and the recovery was slightly better in the CDT groups. So Safety was decent. The 8 events of bleeding were none in the control group. Mortality, no deaths in CDT, while 3 deaths in the control group. Limitation is early termination, and the power is extremely limited, but the long-term findings are exploratory and hypothesis generating. There are a lot of ongoing study on the reduction of the dose of systemic thrombolysis, ultrasound versus anticoagulation, CDT versus anticoagulation, looking at long-term outcomes, the comparing of the large bore thrombectomy with CDT, and we need adequately powered RCTs to check for the efficacy. The indications of these devices remain the high-risk patients who have contraindication to thrombolysis, but unfortunately, in the studies that have been done, they have been excluded. So, intermediate risk with clinical deterioration can also be used. Decision should be based on the PERT team's decision. So, it is the PERT team which is very important here. It's a multidisciplinary team consisting of cardiology, pulmonology, radiology, and the intensivists. Apart from that, you can also include other people. It facilitates a rapid decision making and individualized care, and it promotes advanced therapies when appropriate. So, to conclude, interventional therapies offer promising alternatives, potential to improve outcomes for low bleeding risk. Current evidence is limited because we have seen the patients who will benefit have been mostly excluded in the trial. So, we need more study with proper power, and patient selection and multidisciplinary care will definitely help. Thank you for your patience.